This is case of the day, running strong since March, I think, isn't it? And today we have the 114th case, understanding PLAC injuries. And don't worry, I learnt about this term today and I thought we need to know this better. So this 50-year-old with injury, severe anterior right thigh pain, and I'm still not clear about the mechanism of injury. Doesn't matter. The MR shows a classic complete adductor longus avulsion tear from the pubic attachment. You can see that beautifully here with about a centimeter's gap, and edema and contusion of all the adjacent muscles. And that would be our typical report, and that's what we would leave it at. But that's not enough. So when I was looking at the literature, it all started in 17 from this group led by Ernest Childers, where they discussed something called the pyramidalis-anterior pubic ligament adductor longus complex, called it the PLAC. This is a beautiful picture by Dr. Childers where they show that the anterior abdominal wall in that region, the rectus abdominis, has no role to play. It's the pyramidalis, which connects to the anterior pubic ligament, which connects to the adductor longus, which in turn connects through via the fibrocartilage with the pubic bone. So this entire thing is a complex, and it's very rare to get an isolated injury. If you get an injury of the adductor longus, all of these things would be involved to some degree or the other, and that would then impact management. So even surgeons have to be aware of all of this. So they followed this up a couple years later with this paper where they then compared. So this was all dissection based, and then came the MRI paper, and they described 6 types on whether the pyramidalis anterior pubic ligament was attached or torn from the adductor longus, and whether the pectineus, this is the coronal image, was torn or not. So here, for example, the pectineus is intact, it's type 1, this is type 2. And then very recently came this paper, again same group from the UK, where they've now correlated this with injuries during surgery and found that there was very good correlation, and it makes a difference. So we don't have the paper that says, okay, doing all this improves the long-term result. But the point is, all of this matters, and they've described in interpretation of the MR a 3-step process. But for that, they used a dedicated protocol with axial images perpendicular to the pubic bone. So that would be at a 30-40 degrees angle, and then sagittal and coronal planes perpendicular to that axial plane. And typically for us, this patient who came yesterday, we didn't even have a proper history. All we knew was that there's some right thigh pain. And then it's very difficult late in the evening or at night to plan all of these separately. But you can still use the 3-step process with standard coronal and sagittal images. So the first step is to figure out whether it's normal, whether there's a complete tear or there's a partial tear of just the adductor longus fibrocartilage. So in our patient, you can see on the T2 sag, complete tear of the adductor longus, complete tear on the coronal, again this is the sagittal, and then this is the T1 coronal showing the complete tear. That's the tendon which is avulsed from the pubic bone. So that is clear. The second step is to find out what is the status of the anterior pubic ligament pyramidalis as compared to the adductor longus. Is it torn? Is it intact? Is it a partial tear? This is a little tricky because the plane doesn't go exactly through that. And so when I looked at it and through multiple images, that's the pyramidalis. That black structure is the anterior pubic ligament, and it was completely torn from the adductor longus. Now, because these are black structures, I used MINIPs. So it's a 4-image MINIP. And since each scan was 5 millimeters, ideally they should be 3 millimeters without a gap. I had a 20 millimeter MINIP, and that's the torn adductor longus tendon. That's the pyramidalis anterior pubic ligament, and you can see that there's a gap here. So that's also completely torn. The third step is to look at the pectineus. in the coronal plane, but you can obviously look at it on the sag as well. But you can see here that the pectineus is partially torn from the attachment on the iliopubic ramus. So what we have is an adductor longus fibrocartilage avulsion, a tear of the anterior pubic ligament from the adductor longus. So the pyramidalis adductor longus connection is torn, and there's a partial tear of the pectineus. So this makes it a type 2 PLAC injury. And so to summarize, once we see adductor longus injuries, partial, acute, maybe sometimes subacute, chronic, we need to assess the pyramidalis, not the rectus, the anterior pubic ligament, and the pectineus in sagittal and coronal planes. And if we know in advance, then plan it in such a way that the axial scan plane is perpendicular to the plane of the pubic bone, and then plan the sagittal and coronal accordingly, and then figure out the where this all fits into in terms of the pattern of injury, but use the 3-step process. What's happening to the adductor longus from the pubic bone, what's happening to the pyramidalis anterior pubic ligament connection to the adductor longus, and what's happening to the pectineus, and then put that in the report, and that should be a complete report as part of the PLAC constant WhatsApp channel. I hope I've given you some food for thought today, especially if you're an MSK radiologist, and thank you so much for viewing this.